All right, let's dive into tuberous sclerosis complex. Now, this isn't just a single diagnosis. Think of it more like a clinical puzzle. It's a multi-system disorder where the clues can literally pop up anywhere. The skin, the brain, the heart, you name it. Our job as clinicians is to be the detective, to find those clues and piece them all together. So, let's start with our very first clue. So, picture this. You're in the clinic, and an infant comes in with a few small, pale patches of skin. To a parent, it might look like nothing, totally harmless. But for you, the sharp clinician, this should set off alarm bells. This is a major red flag, and it's often the very first stop on the diagnostic trail for tuberous sclerosis complex. Recognizing this first clue, it's absolutely everything.
So how in the world do a few simple skin patches lead to something as serious as seizures? Well, the answer, as it so often is, lies in the genetics. To connect these dots that seem so far apart, we have to go back to the very beginning, to the genetic blueprint of the disease, and pinpoint exactly what's going wrong in the cellular pathway.
Okay, so at its core, TSC is an autosomal dominant disorder. This means a single gene mutation is enough to cause it. And that mutation messes up a really critical pathway called mTOR. You can think of the mTOR pathway as the brakes on cell growth. It tells cells when to stop growing and dividing, but in TSC, those brakes are faulty. They don't work. This leads to out-of-control cell growth, which is why we see these benign tumors, we call them hamartomas, popping up all over the body. Now, there are two main genetic culprits here, mutations in either the TSC1 gene or the TSC2 gene. TSC1 makes a protein called hamartin, and TSC2 makes one called tuberin. And here's the clinical pearl you need to remember. A TSC2 mutation usually, though not always, means a more severe disease course for the patient. That's a really vital piece of information to have when you're thinking about prognosis. I want you to lock this number in your brain, 75%. That's the percentage of TSC cases that are caused by brand new, spontaneous mutations, what we call de novo mutations. So what does that mean for you in the clinic? It means 3 out of every 4 patients you see with TSC will have no family history of it whatsoever. So you absolutely cannot rule out TSC just because the family history is clean. Okay, so we've got the why, that haywire mTOR pathway. Now let's get back to the what. Our investigation almost always starts with the skin. This is where the first clues usually surface. And for all you dermatologists and medical students out there, this is where you are on the front lines. Your role in spotting these early signs is just critical. Let's break down these pigmentary changes, shall we? First up, and most common, are the hypomelanotic macules, which you'll often hear called ash leaf spots. They are the most common sign, and finding 3 or more of them, bam, that's a major diagnostic criterion, one of the big findings you need to make a definitive diagnosis. Then you have these tiny scattered spots called confetti lesions. They're super specific for TSC, but they're pretty rare, so they're only a minor criterion. And don't forget, about a third of patients will also have some café au lait macules too. Next up are the cutaneous tumors themselves, and remember, these are all a direct result of that unchecked cell growth we talked about. We're talking about the classic facial angiofibromas, fibrous plaques on the forehead, the very unique shagreen patch with its leathery feel, fibromas that pop up from around the fingernails and toenails, and even these large skin tag-like growths called molluscum pendulum. Every single one of these is another crucial piece of the puzzle. Okay, time for a quick pop quiz. You're in the exam room, you've got your Woods lamp out to get a better look at those pale spots. So what's the magic number? What's the minimum number of these hypomelanotic macules you need to find to officially meet a major diagnostic criterion for TSC? 3. That's the number. It's that simple. You find at least 3 hypomelanotic macules, each one over 5 millimeters in diameter, and you have officially checked off a major criterion for tuberous sclerosis complex. It's a simple rule, but it has profound implications for your patient. All right, let's keep going. Let's apply that same logic to another huge clue, facial angiofibromas. You know, those reddish bumps that often appear on the cheeks and nose? What's the magic number here to check off another major criterion? You guessed it, it's 3 again. And the number really matters here. Why? Because you or I could have 1 or 2 of these bumps just as an incidental finding. But when you see 3 or more, that's not random. That's a pattern. And that pattern points very strongly towards TSC.
Now, for a clue that is truly one of a kind, the shagreen patch. It's a type of collagenoma usually found on the lower back. But what makes it so memorable isn't just how it looks, it's how it feels. It's got this pigskin-like or orange peel texture because of these deep follicular openings. It's a tactile diagnosis that, once you've felt it, you will never, ever miss again.
Okay, so just based on the skin findings alone, we could already have a really strong case. But remember, it's not called tuberous sclerosis, it's tuberous sclerosis complex. And it's a complex for a reason. Our investigation can't stop at the skin. We have to dig deeper and look for evidence of that mTOR dysregulation throughout the entire body. The brain is where TSC can have its most devastating impact. Seizures are incredibly common, including a specific, severe type in babies called infantile spasms. And when we look at brain imaging, we see why. We find cortical tubers in a whopping 90% of patients, along with these things called subependymal nodules, or SENS. Over time, these can grow into larger tumors called SEGAs. All of this contributes to the significant neurologic and cognitive burden of the disease, which we often group together under the umbrella term TAND, or TSC-associated neuropsychiatric disorders. Next up on our search, we need to check the heart and the kidneys. In the heart, we're looking for cardiac rhabdomyomas. And here's a huge clinical pearl. These can often be found even before birth on a routine prenatal ultrasound. Interestingly, they usually shrink on their own over time, but their presence early on is a major, major clue. Then, in the kidneys, we're on the lookout for angiomyolipomas. These are benign tumors that can grow quite large and cause serious problems like bleeding. And really, the search has to be head to toe. We need to look in the mouth for gingival fibromas and tiny little dental enamel pits. An eye exam can reveal retinal hamartomas. And in female patients, we have to be vigilant for a very serious lung condition called lymphangiomyomatosis, or LAM. You see, we absolutely cannot leave any stone unturned. Okay, we've gathered our evidence. We have clues from the skin, the brain, the heart, the kidneys, all over the body. Now it's time to build our case. This means we have to formally put together our major and minor criteria to confirm our primary suspect, TSC. And just as importantly, we need to rule out any imposters. So let me throw a scenario at you. Your patient has some classic TSC signs, a bunch of facial angiofibromas and those little confetti lesions. It's looking a lot like TSC. But a good detective always considers other possibilities. What is the number one differential diagnosis that has to be on your mind? The big one you have to consider is MEN type 1, which can also present with very similar skin findings like angiofibromas and collagenomas. It is essential to keep that on your differential. And as you can see here, there are a few other rare genetic syndromes that can sometimes mimic some of the skin features of TSC, so it's good to be aware of them to ensure you're doing a thorough workup. All right, so after we've pieced together all the evidence, we've ruled out the imposters, and we've made the diagnosis, we finally arrive at the resolution. And this is the really cool parts, because this is where the whole story comes full circle. The treatment we have directly targets that faulty mTOR pathway we identified at the very beginning of our investigation. Our weapon of choice here is a class of drugs called mTOR inhibitors, and they basically come in two flavors. We've got systemic agents like sirolimus and everolimus, which are fantastic at shrinking those brain tumors, helping control seizures, and managing LAM in the lungs. And then we have topical sirolimus, which we can apply directly to the skin to treat the facial angiofibromas and even help with the hypopigmented spots. It's just a beautiful example of targeted precision medicine in action. And that really brings us to this pivotal moment in how we manage TSC. With these amazing targeted therapies now in our toolbox, our job as clinical detectives, spotting that first subtle ash leaf spot on an infant's skin, is more critical than it has ever been. So I'll leave you with this thought. As these treatments get even better, and as our diagnostic skills get sharper, we have the very real potential to profoundly change the future and the entire life story for these patients.